Hi, I'm Chris Tackett with Intel's Health and Life Sciences Group, and I'm thrilled to have with me two pioneers in the healthcare analytics space. Dr. Charles Macias from Texas Children's Hospital, where he's a clinical innovation officer, and Tom Burton from Health Catalyst, where he is a co-founder and product development advisor. Analytics is such a promising technology to come to healthcare these days. Can you just share with me some of the things that you're seeing environmentally within not only the hospital, but also health systems and patients overall?
I think for years, doctors have had trouble actually getting to the data about their patients. They put a lot of effort into entering the data into electronic medical records, but it's been harder to look at populations of patients across the board. And so analytics offers insights into patients' lives and how care is being delivered. And I think it's a great opportunity to really improve patient outcomes by understanding populations of patients better.
I think that one of the barriers that has always existed for clinicians is that we are so trained to think about the care that we provide to one patient and sitting at the bedside and understanding what the impact is. And it becomes challenging to say, I want to extend beyond that. I want to know what happens not just to my patient with asthma or to this patient with diabetes, but to the entire group of patients that I treat with asthma, or to the entire population of children with asthma that come to Texas Children's. And our technologies, our data were never really structured to provide that. So it's a place that we didn't see ourselves 20 years ago because that technology didn't exist.
Data is coming from all different areas within a hospital. And can you just share, how do you guys integrating that data from all these different points within the care continuum to make sure that it gets to the care that it needs to be for the doctor to make decisions?
I think you bring up one of the big challenges in that the data today is somewhat siloed. So you have patient satisfaction data sitting over here in this data system, and you have clinical data in the EMR, and you have financial data in the costing system or the ERP system, but those data typically aren't connected. And so an analytics platform can bring data from all of those transactional source systems and integrate it together so that you get a whole panorama of what's going on. You get a panoramic view of what's happening to this patient across the entire continuum of care. And that has tremendous amounts of insights that can be gained by that.
I think that integration that Tom refers to is really important because it's so easy in a healthcare structure, especially when you become as large as us. We're the largest children's hospital in North America, and eventually you get to a point where the left hand potentially could not know what the right hand is doing, and it's a problem when the left hand is really dealing with clinical care and the right hand is trying to execute operational plans or linking finance into the big picture. So beyond simply creating a platform that can combine data, it's actually providing structures where clinicians, where finance people, where operations people understand how to translate that. So it's really converting data into knowledge and understanding what the big picture looks like.
You know, a great example of that project that we worked together on at Texas Children's, we were looking at simple appendectomy cases, and there was not a different process for the complex cases versus the simple case. And we were able to clinically determine that we could have a shorter length of stay in the hospital for these kids that had simple cases. And we were able to combine kind of clinical data, how complex was the case, was there perforation involved, was it a complex case, with more administrative data like how much did it cost, how long was the length of stay, and then some balance metrics like how happy was the patient with their care experience. And when we combine those three, we could do some real projections about if we streamline the care for these less sick, less severe patients, will we still be able to understand the impact financially and from a patient satisfaction standpoint. And we were able to do that, and it was a great improvement, saved money, and improved the quality of the care.
So you're benchmarking or documenting these areas for improvement and probably prioritizing, we're going to get the biggest impact by implementing this type of change in our workflow or this savings that could come to the hospital. If you think about the patient's perspective, what could be what are some of the examples where you've impacted a patient's life or a patient population management area.
Well, I think I think of this as sort of two approaches. There's the acute care model where a single exposure to an index visit, I come in, I have a one-time disease one-time illness that I'll never have again, and appendectomy is probably one of those examples. And in that model, patient satisfaction is all about that single encounter and everything that happens throughout the continuum of that visit. So, was I rapidly diagnosed in the emergency department? Was my referral timely from my primary care physician? Once I hit the hospital, did I get to the OR in a timely fashion? Did I have a necessary radiation to do that, to make that diagnosis? Were all the right medications provided? Was the care comprehensive? Did it engage my family? So you can begin to think about ways that we can assess the quality of care. So the Institute of Medicine's define that safe, timely, effective, efficient, equitable, and patient-centered approaches to care, defining high-quality care. So within that continuum, that acute care begins and ends at one point, and at the point the patient's discharged, hopefully there's no complication, that patient doesn't get readmitted. But that's very different than the chronic care experience where I may come in with a disease like asthma or like diabetes, and the acute attack that that patient receives diagnosis and treatment for is just one bit of the spectrum of that entire continuum of care. So patient satisfaction is different for that model where there's an acute process than the chronic care, which really has to take into account what is everything that gets involved in that care. I mean, part of this is what happens in the schools, what happens with long-term functioning, what's happening with quality of life. If I'm a diabetic, am I really fitting back in to patterns and to growth that really should make my life meaningful and not really create a disability for the rest of my life? And an institution, organization that can track their data and can understand not just what happened with that acute episode, but what's happening with the patient when they leave my institution or when they come back or when they're going elsewhere. What is happening to that quality of life? That's really the power of analytics. That's really saying this goes beyond just what happened yesterday.
Well, you bring up a great point. What happens to the patient when they leave the hospital? And how can we capture Internet of Things data, wearables, implantables? There's a communication of a whole new quantified self happening out there where you could capture your telemetry while you're outside the hospital, and if it's a comorbidity patient, you might want to be able to track their disease state. What are some ways that you see analytics playing a role for once you're outside the hospital?
I think it's going to play an ever-increasing role. We've actually been experimenting on our own Catalyst team members. So we've been doing some wearables where we've been tracking steps and tracking sleep and things like that. And we've actually done some gamification of that using some mobile tools that we've developed to create teams of a number of employees on each team. And they compete against each other for prizes, and it's all about eating right and exercising. And we've seen incredible results, people losing 20, 30 pounds, getting their diabetes back under control. So I think we have a lot of influence as employers that really hasn't been leveraged to the degree it could. We can see how going beyond the four walls of a hospital can have a huge impact.
So you empower the patient to be able to take care of their own disease state or their own health, and through the analytics you're able to capture that and keep track of them. Let me ask you a little bit about where do you see analytics maybe going in the next 3 to 5 years? What's the promise that everyone is waiting for analytics to really start to make a big impact on our daily lives or in a healthcare system or an institution?
Well, one thing I think we'll see a lot more predictive models. You hear a lot of buzz about predictive models, and I can predict who's going to be readmitted, or I can predict who's going to be admitted or have a heart failure problem or an asthma problem. But those predictive models don't become valuable until they're actionable, where we can prescribe different activities or prescribe different actions to intervene to prevent a bad thing from happening or encourage a good thing to happen. And so I think we'll see a lot more actionable predictive models in the future in the next 3 to 5 years.
I think that's probably going to be one of the most powerful places that organizations can be. As clinicians, we're so used to seeing the data reporting when we think of informatics taking us through those 4 stages of the evolution of information. It's simple data reports on what happened to my patient. I can see my lab results. Data analytics, that second phase, what's happening to this population of asthmatics. That third phase, can we create predictive models that tell us, not just for where insurers are using predictive models to tell us about some of the demographic factors that may lead to readmits, but also where are the failures of healthcare, where is the disconnect, where are the more important social events, activities, where that patient won't fare well for functional outcomes, not just where the disease is going. So it becomes much more complex than what insurers are using for predictive models. And I agree with you, taking that last phase to prescriptive analytics, to actually building decision support, but building it in a way that isn't obtrusive, building it in a way where clinicians can really look at the workflow and they don't have to figure things out, where all the complex decisioning happens behind the scenes, and you can build a best practice alert into your EMR. You can design a health maintenance strategy that will automatically tell you, based on these hemoglobin A1Cs for your diabetes, this is what your follow-up should look like. Or it can recognize multiple risk factors that are not just communicating to the clinician, but ultimately having the same signaling going back to the patient. So when you talk about patient empowerment, that's an amazing amount of empowerment where the prescriptive analytics is going back to the patient. The real challenge is tailoring the technology to fit the needs of that family. And we see a diverse spectrum of socioeconomic groups that come into our populations. We see many families in which English isn't the first language. We see a lot of families that are really driven by electronic technologies. And so strategizing for what fits best, I kind of feel like today our biggest gap is in how to communicate with adolescents. I mean, I can be sitting across the table from an adolescent and he's texting me. It's insane, but we need to be able to communicate with them.
Yeah, well, it's a good point. Multiple data sources coming in, different modalities across the hospital and the continuum of care. How do you integrate all of this data sources so you can consume it to make a decision or create a awareness of what's going on with that patient in real time?
I think a key part of that is the architecture around how you ingest that data. And there have been things that have worked well in manufacturing and retail, other types of environments that just kind of break down in healthcare because healthcare is so much more complex. And so what's needed are very flexible architectures and data models that allow for us to create a learning environment where we don't have to know exactly how to design the data structures or design the measurement reports as we begin, and we can work with clinicians in an iterative fashion to learn over time. And we've seen that be the most successful is when we use technology in a flexible way, then we can experiment, we can learn and get closer and closer. I remember we were working on, at Texas Children's, we were working together on a situation where we were looking at asthma patients and we were looking at something completely different. And one of the physicians noticed, wow, there's something in that data that looks interesting. And because we had a flexible analytics platform installed, we pivoted right in the meeting and said, well, let's drill into that, let's look into that. And come to find out, there was an order set that was causing x-rays to be ordered 60, 70% of the time,
yeah.
which were unnecessary. And so, these kids are getting an x-ray, that's extra cost, that's extra exposure. And because the data tools were flexible, the technology was flexible, we could pivot right there, we could answer the physician's question, and they were able to make a change very quickly and reduce that unnecessary chest x-ray from happening almost overnight.
Well, it's wonderful examples where analytics is impacting the patient and the patient engagement and the quality of care. What about on the financial side? how is it improving the financials for hospitals, from a productivity or efficiencies or workflows? How does that fit into a health system?
Yeah, I think it's best to think of the approach to improving healthcare systems, healthcare structures, by looking at the Institute for Healthcare Improvement's triple aim. So in that triple aim, improving healthcare is about improving the patient experience, number one. Number two, improving population health outcomes. And number three, reducing the per capita cost of care. What we have found is that if we focus on the two, patient experience and population health outcomes, by definition, we're creating better quality, and part of better quality is efficiency, and that's financial efficiency as well. So if we develop more effective strategies for delivering care while we're providing more efficient care delivery, by default, we've reduced the per capita cost of care. We've got a number of examples where we've been able, the appendicitis example is a great example, that reduced the cost of delivering care for simple appies by 20%. Just simply getting our structures more efficient and more effective at delivering that care. But I think the real challenge is getting the conversations so that they're always completely aligned, and that a lot of that comes back to the data governance. So you talk about the analytics platforms and what it takes to create that, but I think that there's a piece that resides on the clinician side, the hospital side, the administration side, that may not as much involve information services, information technology, and that's really looking at the data governance. And how does all that fit, and how does clinical operations and finance sit in on every one of those discussions? And as you build each population health model, as you understand the impact you're having on each care process, each disease that's improving, those conversations have to be ongoing. Because an institution, no money, no mission. You've got to understand what the return on your investment is, and there's a real return there. It's a win-win.
Dr. Macias brings up a real key point that when we get better quality, a better patient experience, we also get a lower cost structure. And sometimes people have that backwards. They think, well, if I want better quality, it's going to cost me more. It's actually the reverse. Better quality, more consistent quality is actually less expensive. Part of the challenge are the payment structures are not always aligned. And so a lot of these organizations start working with their insurance companies, and they're actually today incented to provide maybe more care than's necessary. And so I see a shift coming of more and more fee for value. How can we prevent this patient from even getting to the hospital in the first place? Or readmitted. And so as you see a shift in payment structures, then this natural alignment of higher quality care equals lower cost care becomes even more important.
And there's so many different nuggets of data that can be coming into a hospital, being written notes that you have to figure out, how do I capture those written notes in there that I could use to impact a patient's care? Or electronic health records have been around now for quite a while, so how do I integrate that into a single system? I think you mentioned there's a lot of siloed systems. How can I integrate that data together to make sure that I'm making the best decision for the patient and to lower costs?
Well, I think one of the first steps is bringing that data into a connected location where I've integrated financial, clinical, patient experience data, and connecting that very quickly. It can't take years to do that. It needs to take weeks to do that. And so as you bring data into an enterprise data warehouse analytics type of a platform, quickly integrate that data, now you start to see insights in the data that you couldn't before when it was siloed. And that's really the key, is getting those insights faster to frontline clinicians so they can understand their populations of patients better and take action.
Gentlemen, thank you. This has been a wonderful discussion, and we'll look forward to talking with you in future discussions as well.
Thank you, Chris.
Thank you.